50 minutes is a challenge, so I already want to apologize because having listened to Ross Fisher's talk, I realized that I have to give you a lot more easy slides. So off we go. Are all buffers equal? Yeah, maybe. Not an interesting question. So that takes care of that. I've declared interests specifically on the microcirculation, and thankfully I've received money from the industry to support a number of the studies that we have done. I'm a physiologist. I'm not a clinical person, so a lot of what I'm talking about is mechanisms. So that is my declared interest. The first thing I want to declare to you, I think that there is a crisis in evidence concerning the perception of what fluids do and how they are used. I think they're used wrong. This is a very nice slide, and you can see that so-called resuscitation trials are being conducted in patients that don't need resuscitation. All sorts of extreme conclusions are being drawn about the effects of specifically starches, and it is my opinion that all of this is fake news and that you should not read the New England Journal of Medicine. The chest trial is a specifically badly carried out trial in which starches are being given, colloids are being given to patients who are completely and totally normovolemic. Numbers of patients all of a sudden mysteriously disappear from 1,300 to 700 with no explanation, and I can go on. The most important problems in all of these trials is that there is no clear protocol for giving amount of fluids. So volume is never taken into consideration. And that makes, in my opinion, all of these trials useless. So, physiology is the only polar star we have. Luciano says it over and over again. And so let's look at the physiology of fluids. First of all, why give fluids? What is it? It's a knee-jerk reaction, and usually the way it goes is that you have hypovolemia or dehydration. Difficult to distinguish between the two, but that's another story. The heart is inadequately filled. You need to fill the heart. There will be more cardiac output. These are all your expectations. Then you expect this to perfuse the microcirculation with blood, and that will provide the cells with oxygen to sustain organ function. I assume this is the reason why you consider to give fluids. Well, does that happen, all of this? We don't know. It certainly is the expectation. Fluid therapy improves microcirculatory flow to increase cardiac output, essential for treating shock. You see it everywhere, even in the New England Journal of Medicine. But this is what happens when you give large amounts of fluids. You completely dilute for extended periods of time. This is a cardiac surgery patient on pump with no oxygen carrying capacity at all. So why are you giving fluids? Is it to promote tissue oxygenation? Well, if there are no red blood cells, there's no oxygen. Is it to correct acid base? Presumably the person who asked me to talk about buffers thinks so. Is it to promote perfusion? Or maybe all of the three? Let's look at it. So if we look at the different fluids, we have the colloids, the crystalloids, but we're actually going to be talking about the component of balanced versus unbalanced and different types of buffers. So we have the lactate, the acetate, and the saline. So I am going to have to talk a bit about chloride. I want to apologize to the following speaker on this, but you do see that over the years, the amount of chloride in so-called physiological saline has increased. We are now almost 50 millimotors more chloride than you have in your plasma. So giving saline is associated with chloride load. And this has caused a lot of people uncomfortableness, and people talk in the same way as they do about starches, about saline. Starches seem to be banned by the EMA, but not saline, which is curious. But saline does do certain things. So if you look here, looking at Plasmolite, which is a Ringer's acetate buffered Baxter product to sodium chloride, in a hemorrhagic shock model, in a rat, you indeed see that you get a lot more chloride. If you get more chloride, you indeed get more acidosis. We call it dilutional acidosis. This is not metabolic acidosis. It's a different type of acidosis. And in my opinion, one of the problems that people are not able to distinguish between the different types of acidosis. And the strong iron difference indeed goes down from 47 to 12 when you use these. So saline does cause acidosis. and in the clinic too. But if you now are uncomfortable about acidosis and you try to treat it, this may not be a good thing. This particular study looked at that, Australian study from the group of Bellomo. So they said, okay, let's restrict giving saline. So they did. They first had saline group, then they changed their practice and they went over to Hartmann's solution. And indeed, the numbers are small but statistically significant. There's a drop in pH if you use saline. However, if you restrict chloride, you get a higher incidence of alkalosis, which is much worse than acidosis. So you jump from the frying pan into the burning fire, it seems. So I wrote this paper. It was not something I invited, but I was asked to make a case for giving sodium chloride. Why not? Well, we certainly use a lot of the stuff, 10 million liters of it in the UK, 200 million liters in the United States. In the surgical ICUs in the United States, 350,000 patients get saline only, and a very small proportion get rigorous lactate. In our own department, in Erasmus, where I work as a physiologist together with Dr. de Geus, we used in this particular year 11,000 liters for resuscitation of sodium chloride and only 1,500 liters of Ringer's lactate. So even though people say we must buffer and saline is bad, by far, the most used fluid is saline. So there can't be all that thing wrong with it. So are buffers important, really? Or is it just cosmetic, biochemical cosmetic therapy? Well, if we look now at the ideas about how important it is to have a buffered solution, we talk about that we are talking about a so-called bicarbonate precursor. So we expect the lactate and the acetate to be metabolized and to actually make bicarbonate. But there are people that say, well, that's completely misleading. A bicarbonate precursor is really not very important. Generating bicarbonate is not really important. All we want it to do is disappear rapidly. It should be non-toxic. It should be metabolized, or you should pee it out. And it should not influence too much pH, and that's the only thing we really want about fluids. All the rest is useless. Well, if you look at the Cochrane analysis looking at buffered versus non-buffered, there's no difference between the two. So there's no evidence that buffered is really all that better. Now, these people in Canada thought, well, if we give saline to post-cardiac surgery patients and it becomes acidotic, that must be a bad thing. So let's try to biochemically correct the acidosis by supplementing the fluids with bicarbonate. This is what I call cosmetic anesthesiology. It's a very dangerous experiment, as they found to their detriment, because they even took a patent out on this idea. But what they found was that actually supplementing with bicarbonate caused an increase in acute kidney injury. So don't mess about too much with biochemistry. And in fact, there are many studies now that show that even though you might be getting very acidotic, this is a study in anesthesiology, there is no effect on cognitive function and on kidney function and all of these things. In this particular study, for example, sorry, that was a study I mentioned before. Nevertheless, there are studies that are indicating large randomized prospective cohorts showing that giving saline is associated with a lot of adverse effects. So the question then is rises, well, does this have to do with saline? Does it have to do with acidosis? Or does it have to do with the fact that clinicians are inadequately able to give the right amount of fluids to these patients that we're just talking about too much fluids? So is acidosis really all that bad? Well, this colorful gentleman is Christian Bohr. I hope you remember them from your physiology lectures, because his wonderful paper by Handy and Sony calculated the Bohr effect, which is whereas you become acidosis, the oxygen released from the hemoglobin more easily, that if you decrease your pH from 7.4 to 7.2, the actual oxygen that you're delivering to the microcirculation is equivalent to 30% increase in cardiac output. So nothing wrong, it seems, with acidosis. And there's a lot of literature really showing that acidosis is very, very good in protecting cells against the effects of hypoxia. Nevertheless, acidosis does do things, or does it? Again, in this study, where this was a hemorrhagic shock study looking at balanced and unbalanced crystalloid solutions, we saw that indeed the pH, lowering the pH, had a detrimental effect on renal blood flow. Acetate caused a lesser flow, renal arterial blood flow, than did the acetate. And this was directly associated with an increase in the resistance of the renal artery to fluid, as you can see here. However, interestingly enough, if you use acetate, or Ringer's acetate, Plasma-Lyte, you need less volume to target a blood pressure than if you use saline. So whether it is the pH or the fact that it's less volume, but certainly you got a better kidney function when you used the acetate compared to the saline. In my opinion, it all has to do with the volume, has nothing to do with the pH. That's an interpretation. So what about the buffers? Well, this is Alexis Hartman, and he introduced, as you know, Ringer's lactate, and it was basically to give a bicarbonate precursor. Now, there's a certain thing that you have to know, of course, about Ringer's lactate. It has to be metabolized. And it gets metabolized by oxidation, but it also gets metabolized by neoglucogenesis. And when lactate is metabolized, it produces glucose. So you get free for nothing a bunch of glucose. So maybe you should be wary of giving this to your diabetic patients. And he, in fact, measured this too in his original papers, the enormous increase in glucose. So what about the alternative, the acetate? Well, there are certain advantages to acetate because it also gets metabolized in other organs, or that is the idea. So acetate is one. Gluconate is another one. Now, some of our countries, in Holland, Plasma-Lyte has just been introduced. Plasma-Lyte is the Baxter, has got 30 millimolars of gluconate in it. Nobody knows what gluconate does. Even Baxter, when you asked them, does it get metabolized or not? They said, well, you pee it out. But one thing about the acetate is that it gets converted to bicarbonate a lot faster than does lactate. Lactate takes up to a couple of hours, and acetate is metabolized within about half an hour. Gluconate is eliminated, whatever that means. So the advantage of acetate over lactate is that it's solely metabolized by glucose oxidation. All tissues have the enzymes. It is faster than lactate, and it's unchanged in patients with diabetes, if these are important positive things. So we did a liver resection model with Plasma-Lyte, and we actually showed, here you see the gluconate levels, that the gluconate actually is metabolized in the liver. So it doesn't just go out with your urine, it converts into something that we're not quite sure of in the liver. So we thought, okay, let's try the most balanced solution which you could imagine. A thing called Akix. It has everything that you would want, even taurine in it, and insulin and everything. And we tested this in sepsis model, and you basically see that no fluid is successful in improving the pH, the lipid peroxidation, the bicarbonate levels, all of the things that you would expect fluids to be good, improves in hemorrhagic shock, but not in sepsis. And when you look at the microcirculation underneath the tongue of these patients, you see these type of plugged vessels. You understand that just giving some fluids to this will probably make it worse than making it better. So in my opinion, sepsis and fluid is still a completely open debate. And indeed, if you look here at all of the inflammatory markers, this is a septic animal, and you give fluids, you see that all the markers for inflammation go up once you hit it with fluids. All fluids cause inflammation. And Ringer's lactate, because there's no randomized clinical Australian trials associated with these, it is covered, but it is of all of the fluids, it causes the most inflammation. A lot of literature on this. Here we see peroxidase going up. Animals die quicker with Ringer's lactate. Here we have a study looking at TNF, much more than any type of colloid, much more. And then if you look at acetate, it too has got deleterious effects. This is a study done in Norway looking at cardiopulmonary bypass with acetated priming solutions. And there too, they find impaired renal oxygenation, renal vasoconstriction, all of the stuff that people usually associate either with starches or with fluids occurs with acetate too. And we know from early studies, too, that there are other aspects of acetate which are not very nice, in that it causes myocardial depression. This was a very early study of Jean-Louis Vincent. What about the other fluids? Gelatines, terrible for your liver. Except, again, B. Brown is not doing any randomized control studies on this because they will make the same mistake they did with the 6S trial. What about albumin? Albumin, too, causes acute kidney injury. All of them are inflammatory. All of them hit the kidney in unwanted measures. So, I can't believe I'm almost 2 more slides. All fluids are drugs. If you look at the impact of fluids in simple hemodilution to practically all aspects of physiology, they have an effect. It's not just replacing volume. It's as strong a drug as an antibiotic or as a steroid. Blood flow gets redistributed, PO2 changes, hemoglobin is affected, acid base becomes altered, the osmotic balance changes, the volume status gets redistributed, shear stress, autoregulation no longer works in hemodilution, hematocrit changes, the viscosity, which is one of the most important vasoactive physiological parameter changes, and metabolic alterations occur and inflammation. So volume is prime. The less you use, the better it is. And that's why you need a hemodynamic endpoint. And that's why for hypovolemia, colloids are better, because colloids allow you to give a less volume to hit that hemodynamic target than if you would use something like saline. So, this colorful gentleman, Paracelsus, all things are poison. Nothing is without poison, and only dose permits the poison. So I would suggest to you, buffers are not important, but volume is. Thank you very much.